Okay, video number 5, and today we're going to be covering gastroenterology. I have just gotten my kitties back, so apologies in advance if you hear any meowing in the background. Right, question 41. A 60-year-old farmer is given atropine due to suspected organophosphate toxicity. Which of the following cells is unaffected by atropine administration? Is it chief cells, postganglionic parasympathetic neurons, D cells, parietal cells, or enterochromaffin-like cells? Okay, so let's have a little look, shall we? So atropine is what's known as a muscarinic antagonist. So it acts on these muscarinic receptors, which are part of the G protein couple receptor family. So you have muscarinic receptors, and these are activated by the neurotransmitter acetylcholine. These receptors are found in the central and peripheral nervous system, so we covered that in the first video. So atropine is an antagonist of these muscarinic receptors, and this blocks the action of acetylcholine release by postganglionic neurons in the parasympathetic branch of the autonomic nervous system. So already, if we have a little look at what we have here, we're starting to think, okay, atropine very much affects the nervous system. So already, without knowing much else, that should hopefully start to give us a little bit of an idea of what systems are going to be affected by atropine. So to help us a little bit more, we need to look at the vagus nerve. So the vagus nerve is the 10th cranial nerve. There are 12 cranial nerves in total, and we will be covering this in more detail when we get to neuroscience. But for now, just know that the vagus nerve is a little bit special. So the other 11 cranial nerves all work on different aspects and systems, predominantly in the head, hence cranial. The vagus nerve is both a sensory and motor neuron. Don't worry about that too much, we'll cover that later. And this one travels down the body to affect several thoracic and abdominal organs. So as we can see from this little diagram here, it constricts the bronchi, slows heart rate, is involved in peristalsis in the stomach, helps stimulate bile release. You know, it does quite a lot in the it's a big it does quite a lot. It's a very important nerve for our bodies. But of concern to us in this question is that they stimulate secretions in the stomach and stimulate release from the liver and gallbladder. So let's go through these cells in turn, shall we? So first of all, we have chief cells. So chief cells are found in the stomach, and these secrete pepsinogen. So pepsinogen is a precursor to pepsin, and pepsin helps to aid digestion of proteins. So chief cells are stimulated by vagus control. So atropine is going to affect the activity of these neurons and will affect chief cell secretions. And so just remember, when you're reading the question, it asks specifically which one is unaffected by atropine admission, just to make sure you don't get that the wrong way round. Okay, so next we have postganglionic parasympathetic neurons. So again, atropine blocks the effects of acetylcholine on postganglionic parasympathetic neurons, leading to the inhibition of parasympathetic activity. So it's not going to be that one. Next we have D cells. So D cells are found in the pancreas, and these produce somatostatin. This will be coming up quite a lot for the rest of the video. So somatostatin is known as the big inhibitor hormone. It inhibits things like insulin, glucagon, gastric acid secretions, growth hormones, a lot of stuff. But again, you're going to be seeing a bit of a pattern here. So D cells are under vagus stimulation, so these would be affected by atropine. And next we have parietal cells, which are also known as oxyntic cells, and these are found in the stomach lining, and they secrete gastric acid or hydrochloric acid. So these are affected by both vagus stimulation as well as the fact that they are upregulated by another hormone known as gastrin, which is secreted by G cells, which thankfully our diagram has with us here. So although it has two systems, it is affected by the vagus system and it is also upregulated by gastrin because part of the stimulation comes from vagus activity. Again, these would be affected by atropine. So that's ruled out 4, and the only one that leaves us with is enterochromaffin cells. So let's take a little bit of a closer look at this, because I find this question can get a little bit confusing. So enterochromaffin-like cells release histamine into the stomach. Enterochromaffin cells are stimulated by the hormone gastrin, so the same as parietal cells. Now, gastrin is released from G cells, which are found in the stomach, and they are also stimulated by vagus stimulation. So I'm thinking, hang on, how is atropine not affecting this if it's vagus stimulation? You've just gone through 4 that was stimulated by the vagus nerve. Why is this one different? The reason is the stimulation of the stimulation of G cells is through a neurotransmitter known as gastrin releasing peptide, not by acetylcholine. So as acetylcholine is not involved in the stimulation of enterochromaffin-like cells, they're going to be unaffected by atropine. So that leaves us with our correct answer of enterochromaffin cells. And I also have to say, I probably should have put this one at the end. I think this is quite a nasty question compared to some of the others. This is honestly probably the hardest one, so yeah, I probably shouldn't have started with this. But if you didn't get that one right, don't worry about it. We're going to go through a few more and hopefully we'll build up your knowledge. So we'll just carry on with that. And again, if you have any questions, please leave a comment and I'll try to get back to you. But we shall move swiftly on. So number 42, a 70-year-old patient is complaining of increasing epigastric pain and nausea. So epigastric pain is center of the stomach, a little bit raised up, so just below your rib cage. He has been treated extensively with omeprazole in the past, and endoscopy has not revealed any obvious cause for the pain. So omeprazole is a proton pump inhibitor, so that's going to stop acid secretions in the stomach. So an MRI is performed which shows a tumour in the pancreas. You suspect that the cause of this patient's symptoms may be caused by excessive gastric acid secretion, which we'll explain while he was on omeprazole. Which of the following cells normally promote gastric acid secretion? Don't you just love it when a question runs on a little bit from the previous one? Okay, so we know from the previous question that parietal cells are the ones that produce gastric acid. We also know that G cells produce gastrin, which stimulates chief cells. So the answer is nice and easy. It's G cells. Because G cells produce gastrin, so the gastrin is going to promote gastric acid secretion. But let's just go through some of the other ones just so we know what we're dealing with. So, mucosal cells. So the gastric mucosa is composed of mucosal cells which are interspaced by glands and endocrine cells. So mucosal cells compose the epithelial layer, and its role is mainly to provide structure and protection. In addition, like surface epithelial cells, these are going to secrete bicarbonate ions to help neutralize pH. So it's rule out the mucosal cells. Then we have D cells. So we talked about a little bit about this previously. So D cells secrete somatostatin, which is that big inhibitor hormone I was talking about. And it's annoying that S cells don't secrete somatostatin. So the way I like to think of it to try and remember it, D cells stand for denied. The hormone is denied, as is anatomy making any goddamn sense sometimes. So somatostatin denies things, so it comes from the denied cells, so D cells. And then we have S cells. So S cells secrete secretin, and we can blame this bastard for the D cell fiasco. So secretin does not increase gastric acid secretions, but instead increases bicarbonate secretions from the pancreas. So bicarbonate is secreted into the duodenum, the part of the alimentary system immediately after the stomach, before we reach the small intestines. And this serves to reduce the acidity of the food. So secretin actually reduces gastric acid secretions and promotes the neutralization of the acid environment in the duodenum to aid in digestion. So yes, the hormone called secretin actually reduces secretions in the stomach. Contrary to what my voice sounds like right now, I actually quite like the alimentary system, but the naming conventions on some of these really wind me up. So secretin increases bicarbonate secretions as well as some other pancreas enzyme secretions, but reduces gastric acid secretions. Okay? And then, as I said earlier, the chief cells are the ones that produce gastric acid, but they're not going to be promoting themselves. So it's not chief cells. So G cells produce the gastrin, go to the chief cells, they produce the acid, and it's upregulated by the G cells by the gastrin. Okay? Okay. Question 43. A 70-year-old man with Parkinson's disease complains of constipation. This is common in patients with neurodegenerative conditions due to reduced gastric motility. Which of the following occurs in the cephalic phase of gastric secretion? So is it the release of somatostatin from D cells if the pH falls too low? Is it the presence of peptides directly acting on G cells? Is it mechanoreceptor activation leads to secretion of acetylcholine? Is it secretin is secreted by S cells? Or is it direct vagal stimulation of chief and parietal cells? Okay, so now, and because I'm more than 5 minutes into this video, you might be thinking, what the fuck is a cephalic phase? So when it comes to gastric secretions, there are 3 phases. So the cephalic phase of digestion is initiated by the sight, smell, taste, even sometimes just the thought of food. A little bit off topic, but for those of you with an affinity to psychology, you might be aware of Pavlov's dogs. So this was an experiment where they found that dogs salivated when they heard or smelt food. So they started ringing a bell when they gave it food, and they discovered that even when no food was present, if they heard the bell ring, the dogs would salivate. They had associated the sound of the bell with food. So a little bit off topic, and obviously you can delve into Pavlov's dogs, really interesting experiment, but your body actually starts to get ready for digestion before you start eating. You know, have you ever been in a situation where you are hungry and there's food present, but for one reason or another, you're not allowed to eat it? And, you know, you would have felt some of the uncomfortable side effects of the cephalic phase. So during the cephalic phase, there is stimulation of the vagus nerve that goes from the brain and leads to the release of acetylcholine, which in turn stimulates gastric secretion and motility. So this prepares the stomach for food digestion. So you actually get ready to eat before you actually start eating. And then in the gastric phase, this begins when food enters the stomach, and this triggers a stretch response or stretch receptors in the stomach wall and the chemoreceptors that detect the presence of food. This stimulates the release of gastric juices, and that includes hydrochloric acid and pepsinogen, which we talked about earlier, which promotes digestion and further stimulating gastric motility. So just to remind you, pepsinogen is the one that helps to break down proteins. And then in the intestinal phase, this one occurs when partially digested food enters the small intestine, and this triggers the release of hormones such as secretin, cholecystokinin, gastric inhibitory peptide, and we'll talk about these in time. So these hormones help to regulate digestive processes by inhibiting gastric secretion and motility whilst stimulating pancreatic enzyme secretion, bile release, and nutrient absorption in the small intestine. So now we have like an overview of the gastric secretion phases. Let's go through these in turn. So release of somatostatin from D cells if pH falls too low. So vagal innervation of the D cells act to decrease somatostatin release, as somatostatin will act to reduce gastric secretion. So this occurs regardless of the pH in the stomach, and this occurs during the gastric phase that lowers it down. So it's not going to be the cephalic phase for this one, this is the gastric phase. So presence of peptides directly act on G cells. So although this occurs in digestion, it again occurs during the gastric phase and not the cephalic phase. So as protein is digested, small peptides directly act upon G cells to increase gastrin production. This is in effect, I guess you're kind of like a positive feedback loop, so that increases the rate of protein digestion even further. So it's not going to be this because this is also the gastric phase. So mechanoreceptor activation leads to secretion of acetylcholine. So acetylcholine is released as a result of vagal stimulation from the parasympathetic nerve endings. Mechanoreceptors detect this distension and acts to increase gastric secretion, but this is not through acetylcholine release. So this is an incorrect statement. So this is technically not any of the phases. So this is that's just wrong, just wrong. So secretin is secreted by S cells. Yes, that's true, but this occurs in the intestinal phase, not the cephalic phase. So that is incorrect, which gives us our correct answer of direct vagal stimulation. So what happens? So you have the cephalic phase, right? You have the sight, smell, sensory information, and that then results in parasympathetic stimulation of the parietal and enterochromaffin-like cells and chief cells. And as we saw from the previous question, this occurs via vagus stimulation. So you see something tasty, you see that brownie, you see, I don't know what kind of food you're into. I quite like light cheese personally, or Asian food, Wagamamas, love Wagamamas. I see the rice bowl in front of me. I smell it. My brain goes, all the sensory information goes to my brain goes, I really want to eat this donburi, I want to eat the ramen, yes I'm a weeb, leave me alone. That then is going to send information down the vagus nerve to start activating different cells in your stomach, and that's going to get you ready for digestion. So that's the cephalic phase. And you haven't been to Wagamamas, go to Wagamamas. Wagamamas, please sponsor me. Right. Question 44. A 15-year-old patient with cystic fibrosis attends the gastroenterology clinic complaining of fatigue, weight loss, and loose stools. A common cause of these symptoms in this group of patients is pancreatic insufficiency. So that's impaired chlorine transport via the cystic fibrosis transmembrane regulator, or CFTR channel, which can lead to pancreatic obstruction. Which of the following best represents the composition of pancreatic exocrine secretions in this patient? So is it low HCO3, high K+, low osmolality, high Na+, or high Cl-? Okay, so because we're having a bit of a deep dive of this, let's take a little bit of a step back and go, okay, what does the pancreas do? And this is the pancreas here. So the pancreas has both an endocrine and an exocrine function. And for now, we're just going to be focusing on the exocrine function. So the majority of the pancreas consists of exocrine tissue, and this produces and releases digestive enzymes into the small intestine to aid in the digestion of food. So just some of the ones that you should probably be familiar with. So it produces like pancreatic amylase, which helps to break down carbohydrate digestion. Amylase is also produced in the mouth. So if ever you're like eating a bit of bread and you just like have bread on your tongue and you just leave it there for about 30 seconds, it will start to taste quite sweet. And that's because the amylase in your mouth is breaking down the carbohydrates and you get this sweet taste in your mouth. Some other stuff that the pancreas releases. So you have like pancreatic lipase. Lipase is for fat digestion, and then various types of proteases, which protein digestion makes sense. Additionally to this, the pancreas secretes bicarbonate ions, and these help to neutralize stomach acid that enters the small intestine. And this helps create a favorable pH environment for enzyme activity. So if cystic fibrosis affects the pancreas, we would expect bicarbonate produced to be less, hence giving us the correct answer, low bicarbonate or low HCO3. Okay, so you know the drill. So let's look at the other ones. So the pancreatic exocrine secretions is actually going to contain low concentrations of K+. So normally CTFR protein transports chloride out of epithelial cells and into the extracellular space. And this creates an electrical potential that results in passive cation movement into the lumen. So if you have cystic fibrosis, there is going to be less movement of chloride ions through those CTFR proteins, which therefore reduces movement of K+, so a cation, into the lumen. So you would expect this to be low, not high. Next we have low osmolality. So reduced activity of CTFR is going to result in reduced movement of chloride ions out of the epithelial cells and reduce cation movement, so you know, like sodium in particular, which is usually used to create a positive osmotic gradient, drawing water out of the cells and into the lumen. So therefore the osmolality is higher within the lumen, and this creates a thick viscous secretion, which causes some of the congestive symptoms of cystic fibrosis. So if you have cystic fibrosis, you're going to have thick mucus and thick, higher viscosity, higher osmolality. So this is the opposite, and this is kind of the basically the rest of these they're just the opposite way round. So high sodium plus, so pancreatic exocrine secretions are going to contain low concentrations of sodium. So again, normally CTFR protein transports chloride out of the epithelial cells and into the extracellular space, creates the electrical potential, results in passive cation movement. You get the picture at this point. It's the opposite for these ones. Okay, so we shall move on to question 45. So which of these comparative statements regarding glucagon-like peptide 1, GLP-1, and glucagon-like peptide 2, GLP-2, is correct? So, what are these? GLP-1 and GLP-2. So both glucagon-like peptide 1 and 2 are produced in the intestines. So GLP-1 is primarily produced by enteroendocrine cells, particularly L cells, and these are located in the intestinal mucosa, predominantly in the distal ileum and colon. So one of the key functions of GLP-1 is to regulate blood glucose levels. So GLP-1 acts as an incretin hormone, meaning it enhances insulin secretion from pancreatic beta cells in response to elevated blood glucose levels. This helps to lower blood sugar levels after meals, promoting glucose uptake by tissues. GLP-1 also inhibits glucagon secretions from pancreatic alpha cells, which further aids in reducing blood glucose levels. In addition to this, GLP-1 also slows down gastric emptying, and that helps to contribute to the regulation of postprandial glucose levels by delaying the absorption of nutrients from the intestines into the bloodstream. Now, GLP-2 is also produced by these enteroendocrine cells, and this is primarily by a subset of the L cells. Unlike GLP-1, GLP-2 does not directly influence glucose metabolism. Instead, its primary role is in this regulation of intestinal growth and function. So GLP-2 promotes intestinal growth and repair by stimulating the proliferation of intestinal epithelial cells, which increases nutrient absorption and enhancing barrier functions. So that just gives us a bit of an overview of that. Just not relevant for the question, but GLP-1 has also been implicated in protecting the heart, so with cardioprotection, and GLP-2 has been implicated in bone metabolism, particularly in lowering bone resorption. So let's just go through these questions, because I know this is quite heavy biochemistry. I'm sorry if it's like just I find biochemistry, I like it, but a lot of people like struggle to visualize it, and unfortunately I've been trying to look for like useful diagrams, and there's not a huge amount. They're mostly just flow charts, to be honest. But let's go through these and try to just kind of talk through them and see what there is. So let's go through these one by one. So the half-life of GLP-1 is longer than GLP-2. In fact, the opposite is true. So glucagon-like peptide 1 has a relatively short half-life of only about 2 to 3 minutes, whereas glucagon-like peptide 2 has a longer one, which is about 7 to 9, give or take. So this is the opposite way round. So it's not going to be option 1. GLP-1 is released from L cells, but GLP-2 is released from K cells. Well, no, we were kind of talking about that, weren't we? So both of these cells are produced by enteroendocrine cells located in the intestinal mucosa. GLP-1 is primarily secreted by L cells, whilst GLP-2 is primarily secreted by a subset of L cells. But there is no evidence to suggest that it's released from K cells. So that is incorrect. So L cells, yes. K cells, no. GLP-1 and GLP-2 are secreted in a 2-to-1 ratio respectively. No. Both of these are secreted in a roughly equimolar ratio, so roughly 1-to-1 in response to the same stimulus. So they're both stimulated by the ingestion of glucose at the same time. So it's going to be a 1-to-1 ratio. That'd be a correct statement, but it's not. It says 2-to-1, so no. So this is incorrect. Their actions are mediated by 2 different types of receptors. So this is an iffy one. I don't like how this is worded. And apologies, I know there's been a few questions where I've gone, oh, I don't like this. But I don't like the fact that it's not too clear. This is a bit of a semantics thing. So both GLP-1 and GLP-2 are mediated by highly tissue-specific G protein coupled receptors. So GLP-1 acts primarily through the GLP-1 receptor. So yes, that is a G protein coupled receptor. And this is expressed in various tissues: pancreatic beta cells, gastrointestinal tract, heart, blah, 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 blah. On the other hand, GLP-2 acts primarily through the GLP-2 receptor, which is also a GPCR, so also a G protein coupled receptor, but then it's mainly expressed in the gastrointestinal tract. So this one annoys me because technically, yes, these are two different types of receptors, but if you had answered that this was the correct answer, in the mark scheme that I have for this, you would have gotten it wrong, as the question is saying because both are G protein receptors and as such part of the same receptor family, that they are not two different types of receptors. So, but they are two different receptors with two different names, but it should have said like receptor family rather than types of. Again, it's a semantic argument, and it really annoys me because if you watching this, if you had said that this was the correct answer, I would have said, yeah, you know, that's ambiguous, you could have easily gotten the mark. But from the mark scheme, this is classified as wrong. So I think I'm actually going to give this a different color. I'm going to give this a red, because it kind of turns down to like your interpretation of the question. Like when it says different types of receptors, to me that isn't saying different type of receptor family. That's like, yeah, I've made my point. Okay, so this is technically not the correct answer, but if you did put this, I could see why. And I know with some exams, sometimes if two questions are a bit ambiguous, they might give you the mark anyway. Yeah, I don't like they put this. But regardless, now that my bitching is out of the way, the correct answer to this is that GLP receptor is expressed in more tissues compared to GLP-2, which I was kind of talking about with the previous one. So yes, the GLP-1 receptor is expressed in a wider range of tissues compared to the GLP-2 receptor. So GLP-2 is mainly expressed in the gastrointestinal tract and the brain. GLP-1 is expressed in pancreas, intestines, stomach, central nervous system, heart, pituitary, lung. It's kind of all over the place, and that's the main differentiator. So that would be the correct answer. Again, I'm a bit bugged by this, but this is the argument they will say, is that it's a single best answer. So which one is more correct? And so you would be inclined to go for that one, but it's a little bit shitty. But regardless, this is the correct answer. This is the correct answer, and we shall move swiftly onwards before I develop an aneurysm. Question 46. A 35-year-old patient with Crohn's disease and previous resection of the small intestine attends the gastrointestinal clinic complaining of diarrhea. You suspect he may be suffering from malabsorption secondary to his previous bowel surgery. Which of the following stimulates hormonal secretion during the intestinal phase of pancreatic secretion? So is it increased pH in upper intestine, sight and smell of food, presence of peptides in the antral lumen, presence of fat and protein digestion products in the upper intestine, or gastric intention? So we talked about these phases a little bit earlier, didn't we? So cephalic, gastric, and intestinal phase. So the cephalic phase is triggered by the sight and smell of food, so we know it cannot be number 2. We can just rule that one off the bat. So what causes hormonal secretion during the intestinal phase? Well, okay, let's think through this a little bit logically. So the intestinal phase begins when chyme enters the duodenum, and this triggers a hormonal and nervous response. So the presence of partially digested food in the duodenum stimulates the release of hormones such as CCK, secretin, and gastrin inhibitory peptide. And this is released from the enteroendocrine cells in the intestinal mucosa. So cholecystokinin, or CCK, stimulates the secretion of pancreatic enzymes. You know, that's those good things we were talking about earlier, like lipase, protease, amylase, and also bile from the gallbladder, and that helps to aid in digestion of the fats, the proteins, the carbs. Secretin stimulates the secretion of bicarbonate-rich pancreatic juice. We'll talk about that earlier. And then we have gastric inhibitory peptide, which inhibits gastric motility and acid secretion. So this slows down gastric emptying and allows more time for digestion and absorption in the small intestine. So the intestinal phase begins when chyme enters the duodenum. The duodenum is part of the upper intestine or small intestine. So the answer most correct would be the presence of fat and protein digestion products in the upper intestine. So increased pH in upper intestine. So it's actually decreased pH that is a key stimulus for the intestinal phase of exocrine secretion. So it's not going to be an increased pH. Presence of peptides in the antral lumen. So the presence of peptides in the antral lumen is a key stimulus, well, also that and gastric distension during the gastric phase. So this is the gastric phase 1. And then I literally just said it's gastric distension, didn't I? So presence of fat and protein digestion in the upper intestine. Right, question 47. A 60-year-old man presents to the GP complaining of his eyes going a yellow colour. He has lost over 10 kilograms of weight in the past 3 months. He also tells you that he has noticed his stools have been pale and his urine has been darker recently. Which of the following is most likely to cause his symptoms? So is it reduced breakdown of bilirubin by gut bacteria, excessive hemolysis, cholecystasis, impaired bilirubin conjugation, or hepatitis? Okay, so this yellowing of the eye that we're getting from this patient is a form of jaundice known specifically as scleral icterus. So the yellowing occurs due to elevated levels of bilirubin in the bloodstream. So bilirubin is this kind of like yellow-orange pigment, and this is produced during the breakdown of heme. So that is the iron-containing component of hemoglobin found in red blood cells. So if there is an excess of bilirubin in someone, we know that something is going wrong with the red blood cells. And there's a few things that could be going on. So there could be excessive hemolysis, so that is the breakdown of red blood cells. There could be impaired uptake. So bilirubin is released from the breakdown of hemoglobin, and that is transported to the liver, where it is taken up by hepatocytes, so by the liver cells. So maybe something is interfering with that process. So let's have a little bit of a look at what this gentleman is presenting with and try to get a picture of what's going on. So, lost over 10 kilograms of weight in the past 3 months. This right here is the the king of red flags. Whenever you hear unexpected weight loss, I mean, okay, it doesn't say that it's unexpected in this question, but you know, if you were seeing a patient face to face, you would ask, oh, you know, have you been on a diet recently? Have you not been eating as much? Have you been stressed? You know, what's going on there? In a medical question like this, if it does not specifically state a reason for the weight loss, then you should assume cancer. So cancer are cells which have basically stopped listening to other cells through intracellular communication, and they will just absorb as many nutrients from around them and continue to grow and divide. They don't give a fuck what anyone else is doing. They're doing their own thing. And this is, you know, why you get tumors in cancer. So this gentleman, we're already strongly suspecting he has cancer. So next, what else does he have? His stools have been pale and his urine has been darker recently. Okay. So what could be causing this? Well, normally bilirubin is produced in the bloodstream and it's produced in its unconjugated form. In this state, it is not water soluble, so it's quite difficult to get rid of. So unconjugated bilirubin is brought to the liver, where glucuronic acid is added to it by the hepatocytes, the liver cells. So this in turn transforms it into conjugated bilirubin, which is now water soluble. This conjugated bilirubin is then excreted into the bile ducts, where it ends up in the intestines and is metabolized by the gut microbiome. So if someone is having pale stools, that suggests that for one reason or another, that bilirubin is not making it into the intestines, and this is most likely caused by a blockage in the bile ducts. So if the patient has cancer, then it stands to reason that it's this cancer that's most likely causing this obstruction. So instead, this bilirubin, because it can't be released into the intestines, this is accumulating in the bloodstream, which is what is leading to the jaundice symptoms of this patient. There's more bilirubin in the bloodstream, you can't go anywhere, so you're getting yellow eyes. Sometimes you get yellow skin as well. That's what jaundice is. And instead, the body is trying to get rid of this bilirubin by filtering out through the bloodstream via the kidneys, and that's what's leading to the darker urine. It's not going into the intestines as it should be. It's instead having to be filtered out by another mechanism, so we get the darker urine from the kidneys. So the correct answer here would be cholestasis. So cholestasis is a condition characterized by bile drainage being prevented. Because this occurs outside of the liver, it is known as either a post or extra hepatic. So pre or intrahepatic is when it's in the liver, then post or extra hepatic is when it's outside. In this case, the cause of this cholestasis is most likely going to be that pancreatic cancer, particularly if there's accompanying weight loss. So have we got, see if we can see it up here. So sometimes look where the bile duct is passing through it. If this person has pancreatic cancer and say there's like a tumor around here, or the pancreas is going to get larger, this is then going to push in on the common bile duct, and then you cannot get it flowing through because that tumor is pressing against it. So in the case of this individual with pancreatic cancer, that's most likely what is obstructing the bile duct. So we'll just quickly go through the other ones and try and see why it isn't those. So, or at least try to understand why we would be going for cholestasis and not the other ones given the clinical presentation. So reduced breakdown of bilirubin by gut bacteria. So yes, the stools are pale due to a lack of stercobilirubin, but this is due to less bilirubin entering the gut as a result of this bile duct obstruction, not as a result of the reduced breakdown of gut bacteria. So it's not going to be this one. Excessive hemolysis. So pale stools and dark urine are characteristic of post-hepatic jaundice, and therefore obstruction of the common bile duct is the most likely explanation for this patient's symptoms. Excessive hemolysis leads to an increase in unconjugated bilirubin, which is water soluble, and therefore will not cause pale stools and dark urine, so not this one. Impaired bilirubin conjugation. So this is a case of obstructive jaundice, which is post-hepatic in nature, the question, whereas impaired bilirubin conjugation would be pre-hepatic jaundice. So this patient has post-hepatic jaundice. If it's caused by impaired bilirubin conjugation, it's going to be pre-hepatic jaundice up in the liver. And a good example of that would be something like Gilbert syndrome, which conveniently enough we'll be covering in the next question. So it's not going to be impaired bilirubin conjugation. And then hepatitis, again, it's just not the most likely explanation. If you have pale stools and dark urine, think some kind of obstruction. That's where you should be going with it. Okay, so question 48. A 20-year-old patient presents to A&E complaining of his eyes going a yellow colour. He has no past medical history or family history. His blood results show high bilirubin and normal hemoglobin levels. You suspect that this may be a result of Gilbert's syndrome, which is a result of reduced activity of the enzyme glycerol transferase. Which of the following signs and symptoms would you expect to see in this patient? Pale stools and dark urine, with our previous one, steatorrhea, no other signs, dark urine only, or pale stools only. Okay, so Gilbert syndrome is a relatively common and benign genetic disorder that's characterized by mild unconjugated hyperbilirubinemia, which means there are elevated levels of unconjugated bilirubin in the bloodstream. And unfortunately, this was the only image I could find to talk through. Most of the others just showed yellow people, and some celebrity actually, who I'm not aware of. So there's a few conditions here trying to get bogged down. So again, just focus on Gilbert syndrome here and the UGT1A1. Okay. So in individuals with Gilbert's syndrome, there is a deficiency in the enzyme UDP glycerol transferase, or UGT1A1. And this is responsible for conjugating bilirubin in the liver. So conjugation of bilirubin with glucuronic acid, which we talked about earlier, is necessary for its excretion into bile and subsequent elimination from the body. So the reduced activity of the UGT1A1 enzyme in Gilbert syndrome leads to decreased conjugation of bilirubin and consequently elevated levels of unconjugated bilirubin in the bloodstream. So we saw in the previous question that dark urine and pale stools is more characteristic of post-hepatic blockage. So we know it's not going to be any combination of that. So it's not going to be pale stools and urine, it's not going to be dark urine only, and it's not going to be pale stools only. So the only one that leaves us with here is this new one that we haven't come across, steatorrhea. And this refers to pale fatty stools, and that's caused by an increased levels of fat in the stool. So steatorrhea, which is associated with like malabsorption or maldigestion of fats, you're going to be thinking something a little bit more intestinal, not Gilbert syndrome, which is more of a blood disorder. So Gilbert syndrome primarily affects bilirubin metabolism and does not impair fat digestion or absorption, not typically in the nature of like the absolute zebra of zebras. So this one is actually a little bit of a nasty question because it's almost like a trick question. The correct answer is actually there are no other signs. So yeah, Gilbert syndrome is relatively mild, and usually the only condition, the only symptom they will be showing is jaundice. So you usually have a little bit of yellow of the eyes, sometimes a little bit of the skin, and that tends to fluctuate a little bit whether they're fasting, if they're dehydrated, if they're stressed, or if they're ill with something else. But for the most part, Gilbert syndrome is a relatively benign condition, so it does cause occasional yellowing of the eyes, these flares-ups, but it doesn't usually cause any other symptoms, so it is no other symptoms. Right, moving swiftly onwards. Which of the following is required for absorption of vitamin B12? Is it aphamin, intrinsic factor, albumin, GC globulin, or retinol binding protein? So let's have a little look about how this is absorbed. So vitamin B12 is absorbed primarily in the distal part of the small intestine, so the ileum, so around these regions. And this requires the presence of intrinsic factor. And this is a glycoprotein that is secreted by parietal cells of the stomach. So there'll be some questions going on in gastroenterology. So parietal cells, intrinsic factor. That seems to come up quite a bit, so remember that. Parietal cells, intrinsic factor. So intrinsic factor forms a complex with B12 in the stomach, and this protects it from degradation by stomach acids and enzymes. So it basically just stops it from being digested. You need to keep it whole. It's like a little shield that goes around it. No, don't write that in. Don't write that in your essay. It's not a shield. Don't do that. That's so medically wrong. So this complex travels to the ileum, where it binds to specific receptors on the surface of the epithelial cells. And then through receptor-mediated endocytosis, the intrinsic factor vitamin B12 complex is internalized into the enterocyte, and that allows for the absorption of vitamin B12 into the bloodstream. So the correct answer is intrinsic factor. So think parietal cell, intrinsic factor, B12, just link all of those in your brain, because they will almost undoubtedly ask you a question about this. They seem to love it. I do not know why. So what are the other ones? So albumin. So albumin is a plasma protein, and that belongs to the albumin gene family, and it functions as a carrier protein for the transport of vitamin E in the bloodstream. So albumin binds to vitamin E, and it helps to solubilize it and transport it to various tissues. So important, not the answer not the one we're looking for. Albumin is the most abundant protein in the blood plasma. Serves all sorts of functions. So it helps to maintain colloid osmotic pressure, transports hormones, fatty acids. It's a bit of a helps to buffer pH and drugs. So again, that's more of a bloodstream one that isn't related to the intestines. GC globulin, this is also known as vitamin D binding protein. I wonder what that could be. Is a carrier protein that, funnily enough, binds to vitamin D, and it helps metabolites in the bloodstream, so facilitates their transport to target tissues. So not the intestine. That's no. Then finally, retinol binding protein. So that's again another carrier protein, and this one binds to vitamin A. Again, it's in the bloodstream. So on this one, so intrinsic. Oh, why have I made that green? What am I doing? Ugh. Black. Where's black? What am I doing? My brain's turned out. Right. Okay. Yeah. Intrinsic factor, B12, always be thinking that way. And finally, question 50. Nice, lovely, easy one to finish off. So, which of the following inhibits exocrine pancreatic secretions? Is it secretin, cholecystokinin, or CCK, acetylcholine, vasoactive intestinal peptide, or somatostatin? So what did I say at the start of this video? Somatostatin is the big inhibitor enzyme. In fact, these are all the things it inhibits. So if the answer to the question, what's going to inhibit exocrine pancreatic secretions? Well, it's going to be somatostatin, isn't it? There you go, you can stop now. If you're done hearing my voice, that is the end of it. But I'll just talk through a little bit what these other ones are doing if you are interested. So somatostatin is produced by the delta cells of the endocrine pancreatic islets. And it's released into the blood after a meal, and it has many inhibitory effects on its target organs. So D cells within the antrum of the stomach can also secrete somatostatin, and this inhibits, well, everything. Not everything, but a lot of things. Inhibits secretin, CCK-induced pancreatic secretions, so that in turn will reduce aqueous bicarbonate secretions from the acina cells and pancreatic enzymes from the centroacina cells. So it does. It's the big inhibitor. If you think somatostatin, it's like, okay, what are you denying? What are you denying today? Again, D cells, somatostatin, denier. So let's have a little look at these acina cells, because this is going to come up quite a bit. So acina cells are specialized cells found in the exocrine portion specifically of the pancreas, and this is known as the pancreatic acini. So these cells are responsible for producing and secreting digestive enzymes into the pancreatic ducts, which eventually empty into the duodenum. That is the first part of the small intestine. So you can see it empties into this duodenum. So stomach, duodenum, and yeah, the pancreas like sits behind the stomach. So why is it not the other one? So secretin. So this was the annoying one I was talking about earlier, which increases secretion in the pancreas and decreases secretions in the stomach. So entry of acidic chyme into the duodenum stimulates release of secretin from S cells into the blood. And this binds to central acina cells in the exocrine pancreas and stimulates aqueous bicarbonate release. So this is going to increase... Oh my God, why am I doing this? This is going to increase secretions, not inhibit it. And basically that is the story for all of these. So CCK, that's released in the presence of semi-digested fats and peptides in the in the duodenum, and this will cause more secretions. Acetylcholine, the pancreas is innervated by parasympathetic nerve fibers. Because this is part of the rest and digest system, so acetylcholine as part of the parasympathetic system is going to increase pancreatic secretions, so not that. And then vasoactive intestinal peptide. This is secreted during the cephalic phase. So when you see that tasty brownie, that's going to be released, and this again increases exocrine secretions. So our correct answer is somatostatin. D cells, somatostatin, denied. Just think that way. Anyways, I'm going to head off because I can feel my voice absolutely going. I hope you learned something from this, and I will see you all next time, you beautiful people.